Hi, good afternoon and good morning, everyone. Thank you very much for your time joining us. And today we are very happy to have four speakers for us to share their experiences with NICS. And I'm going to introduce the first one, Dr. Yaxin Yao. Dr. Yaxin Yao, she had her PhD in embryology from Chinese Academy of Agricultural Sciences. She is also selected for the Jiangsu Provincial Double Innovation Doctor Program. She's actually the director of our clinical research department. And with the team, other experts together, she developed the non-invasive chromosome screening technology. She has also successfully led the team and to realize its productization and industrialization. Also, as the scientist lead, she has been responsible for organizing, managing dozens of single and multi-center clinical studies. She has participated in 2 projects of the National Key Research and Development Program and published more than 20 papers, and she holds 5 national patents. Today, we're glad to invite her to give us a talk, and the topic is the overview of non-invasive embryo chromosome screening. Please welcome Dr. Yao.
Hey, thank you for Nana. Can you see me?
Yeah.
Yes.
Okay, let me share the screen. Okay. Can you see my slides?
Yes, very clear.
Yeah, thank you. Good afternoon, everyone. I'm Yaxin Yao, and you can call me Michelle. I'm really appreciate being the first speaker here and talk about the overview of non-invasive embryo chromosome screening. Yeah. Yeah, let's see the overview of the past 8 years about the NICS. Let's start with the global first NIPT baby born in Wuxi, China. That is the very beginning of NICS and means from 0 to 1. And then maybe the question arose, is it accuracy enough, and how it's used, and for whom will be benefit from this technology, and how about large scale validation? Yeah, and then we did a large scale validation to answer the accuracy issue and built an AI model to answer how it works. After that, the single center clinical trials have been excluded. Wow. I'm sorry for the there is some, sorry. Yeah. Let's go back here. Yeah. Let's sorry. And let's talk continue with the AI model. And we built it to answer how it works. And after that, the single center clinical trials, we want to explore the indications and to answer who will use it. And then a big size multi-center RCT was conducted. We collect big size data to answer the efficiency of NICS. Yeah. Meanwhile, more than 1,000 healthy new babies has been born from the clinical trials. Sucked. I'm sorry for there's sucked to my PPT. 这边的不行，我出来。 清楚。哎，上不去了。I'm sorry for the interrupt. I'll share the screen again. Okay. You see? Yeah. Maybe there is something wrong with the PPT slide, so I will open it like this. Yeah. Okay. Meanwhile, we published a series ICI papers and such as the accuracy validation, the recommendation for how to use and some clinical applications. Yeah, let's look at the NICS research processing. Yeah, the NICS development from the pair of 42 bacillocystis and cultural medium. Yeah, we checked the performance of NICS and use the whole embryo as the gold standard. And the performance is quite impressive. We got 88.2% for sensitivity and 84% for specificity and 78.9% for positive predicted value and 91.3% for negative positive value. Yeah, and this result and NPV quite encourage us. So we applying it to the first 7 patients. Yeah, and then I remember 5 live births, new babies in because of NICS. Here is the first baby. He is already 8 years now, born in Wuxi, China in 2016. Yeah, and then. My God. I'm so sorry. Yeah, and then we did additional accuracy validations. The first one, we used the 52 donated frozen blastocyst and also used the whole embryo as the gold standard. We compared the NIPGTA with the TE biopsy, also compared to the whole embryo separately. Then we find the NIPGT-A is more reliable, even more reliable than the TE biopsy in this study. Another one is a big size validation. We used 2060 and 64 donated fresh embryos. And we also use the whole embryo as the gold standard. And here we find NICS as is quite comparable to the TE PGT, and they have a similar performance. Also, in all of these periods, accuracy validation, we use the ICSI fertility embryos. And in this study, we use conventional IVF embryos. You know, there is something, some concern about how to use the IVF embryo span cultural medium. We'll feel concerned about the sperm will be amplified or not. So we amplify the sperm first. Here we find the failed sperm DNA amplification in the current condition system because the condition system is gentle currently. Yeah. And we also find there is no paternal contamination was observed in the conventional IVF SEM. And also we find the IVF and ICSI fertility embryos have the similar performance, even better. The IVF fertility embryo even better than the ICSI fertility embryos here. And in the same study, we find the NICS results can be categorized into can be classified into 6 categories. Yeah, we find the euploidy probability of embryo with different NIPT results, such as the NICS aneuploidy, the high-level mosaic, the multiple chromosome mosaic, and even the low-level mosaic, 6 chromosome mosaic only, and the euploidy. And you can see here, compared to the TE biopsy as the gold standard, the different groups predict a different probability normal in the TE biopsy. So we want to upgrade the NICS rating system to an AI system. Yeah. You can see here, we built an artificial intelligence ratio for embryo optimization based on the CNV results. And we input the euploidy probability compared to the MATE gold standard. And after my presentation, Dr. Chen's group will tell the details how to build AI system. In my presentation, I will tell us we recommend the embryo should transfer in the ABC disorder. Yeah, let's look at the comparison of the clinical outcomes between these different rated embryos. First, you can see here the clinical outcomes of the grade A and B transferred after NICS optimization was significantly better than the grade C embryos, and grade A and B had quite similar outcomes. Yeah, and after that, we did a very interesting we make a very interesting essay. Here, we use the same data and same samples through 2 different analysis methods. The first analysis method, you can see the inner cycle. We classified NICS CNV data into euploidy and aneuploidy. Yeah, you can see the euploidy rate is 57.9%. And the outside, we use another analysis method. We use the NICS grading system, and we can see the A plus B is 78.8%. Yeah, and if we classify the euploidy and A plus B also benefit them to be an acceptable embryos, we find that the utilization of the embryo can be upgraded to 20%, even when the grade A and B have the similar pregnancy outcomes versus the euploidy. Yeah. This the previous PPT we showed is quite exciting results, but they are all observational results. In the next slides, I'll show you the prospective interventional clinical studies. Yeah, and here is the first pilot study. We enrolled the patients with the repeat pregnancy loss, and that means more than 3 times the pregnancy loss, and repeat implantation failure, that means 3 times failure. Yeah, and a total of 52 euploidy embryos was transferred in the 43 RPL and RF patients. Here we get totally 58% pregnancy rates, and 27 healthy babies were delivered in the end. So encouraged from this pilot study, we did another subclinical RPL and RF single center studies. Total of 273 women with a history of RPL and RF, and the patients with RPL more than 2 times or just once with abnormal product of conception. We can find the NICS reduce the incidence of miscarriage and increase the ongoing pregnancy rate. And the patients with the RF more than 2 times, we find the NICS can increase the clinical pregnancy rate. Yeah. There is another big concerns about the NICS. That may be that NICS can comparable with the PGTA. How about the efficiency of the NICS compared to the PGTA? So we conduct a 3-arm cohort study, NICS versus PGTA versus morphology. When the patients were enrolled, we grouping them by self-selection to PGT group and the ICSI group. The PGT group will randomize into NICS and the PGT, the 2 groups, and they also transfer the euploidy embryos. And the ICSI group will transfer the embryos followed by the morphology score. Yeah, and let us see the outcomes. Yeah, it's a quite important outcome is the cumulative live birth rate. That's our primary endpoint, cumulative live birth rate. We find the live birth rate was significant better both in NICS and the PGT-A group than in the ICSI group. And there is no statistical difference in clinical outcomes between NICS and PGT-A group. But you can see here, there is a little lower live birth rate in the NICS group. That may be because NICS get little less euploidy available embryos in this group. Yeah, and but in our FET cycles, we find there's no statistical difference in clinical pregnancy rate, miscarriage rate, live birth rate between NICS and PGT-A group. And in terms of live birth rate, NICS A and PGT-A groups was higher, also both higher than the ICSI group. There is another very interesting data here. You can see the newborn baby data. NICS group had a significantly higher newborn baby weight than TE-PGT group here. Yeah, that may be because NICS is a non-invasive method, but the TE biopsy PGT is an invasive method. Maybe in the near future, we will design assay to do the further research. Yeah. And there is another clinical study from Hebei Reproductive Center. Yeah, the patients were enrolled and then also grouping by self-selection of themselves. And the NICS group here is quite different from the previous study. Yeah, in this group, the patients, the embryo will transfer follow the grading A, B, C. Yeah, we define the acceptable embryo in this NICS group is A or B is also acceptable embryos. And we can see here the number of blastocysts rated as A plus B account for 66% here. And in the control group is just a transfer according to the morphology grading. Yeah, let's look at the outcomes. We can see here the clinical pregnancy and ongoing pregnancy rate, live birth rate are both higher than the control group. And there is a subgroup here about female age. We can see compare to the control group. When the female age elder than 35 years old, yeah, here we can see the outcomes were significantly better than the female age younger than 35 years old. Yeah, so encouraged with of the period study, the single center studies, we decided to conduct a large size RCT clinical trial. Yeah, and in 2030, the SNI-PGT here was led by Peking University's third hospital, Professor Qiao Jie as the leading PI here, and our Econ Medical was the sponsor here. Yeah. And what's the meaning of SNI-PGT? SNI-PGT means the embryo selection by non-invasive pre-implantation genetic testing. And we registered the clinical trial in the clinicaltrial.gov. And here you can see here. And we want to enroll the 1,148 couples aged from 35 to 42 in the group. Yeah. And then we randomize these patients into the NIPGT group and the morphology group. In the NIPGT group, the embryo will transfer according to the NICS ABC. I mean the ABC grading in this order. And the morphology group, the embryo was transferred according to the morphology score. And this clinical trial is almost complete, and you can waiting for the result in the near future. Over 1,200 cases have been enrolled in this study. Yeah, and yeah. Overall, there are 230 centers use NICS for the global centers. Yeah, and there are more than 40 embryos was detected the embryo with NICS, and we are grading the embryo with ABC, and we find it 30 to 30 to 30. That means there are more than 60% embryo will be used in the NICS detection. That means the embryos was availed visiting with NICS detection. Yeah. Yeah, from 2016 to 2024, the cumulative number newborns baby exceed 1,000. The population will benefit not just the RPL and the RIF patients, also the frozen size cycles, and even the advanced aged PGT-A and PGT-SR patients. Yeah, and then there are still other patients, still other potential benefits. For patients with subclinical RIF and RPL, more than twice failed implantations and more than once miscarriage, NICS has the potential to improve the pregnancy rates and reduce the miscarriage rates. And for patients who encounter the first cycle value and PGT-A mosaic or detection value, NICS can be conducted by using the freezing sign culture medium. For centers unable to perform the embryo biopsy and CNV detection, the span culture medium amplification concentrations has the potential to predict clinical outcomes, and these results we will publish in the near future. And the preliminary results of the multi-center clinical trial also show that NICS has the potential to improve the clinical outcomes of suboptimal embryos based on the morphology. Yeah. Also, there is some limitation of NICS. The first one is the maternal contamination. Yeah, the current solution is a standardized sampling protocol, such as remove the column cells. And the other solution is decontamination using the bioinformatics analysis to correct the false positive and false negative. Here, we show the whole picture of how to standard sampling. How to standard sampling. Yeah. Before you choose the most suitable solution, 2 points should be confirmed. The first one is you want to collect cultural medium from the fresh cycle or the frozen side cycle, and in your center, the cultural method is sequential or just one step. Yeah, for example, if in your center you want to collect the fresh cycle and you choose the sequential culture method, and you freeze the embryo on the morning of day 5, you should collect the medium from day 3 to pre-freezing. And key points of the protocol is remove the columns again on day 3 and culture in single micro droplet. Then culture to the stage 4 blastocyst and even collect spent culture medium and blastocyst fluid together. Yeah, and if you center use the one-step culture, you should collect the medium from day 5 to freezing. And the key point is the embryo should be cultured for 6 to 8 hours and in the 10 microliter single micro droplet. Yeah. And also should collect the spent culture medium and blastocyst fluid together. And then the other solution is the contamination by the bioinformatic analysis. And here we show the results before and after correction. Yeah, and a pair of whole embryos and culture medium through the ratio of the XY mosaic rate, we can calculate the ratio of contamination through the bioinformatic analysis. And after the correction, we can correct the sex chromosome mosaic to the eukaryote, get same results to the whole embryo. And there is another decontamination example. Yes. This example is an eukaryote. We can also calculate the ratio of contamination is about 40%. And after correction, we found the same chromosome 19 here abnormal as the whole embryo. Yeah. Okay, in the end, let's talk about the future prospect. We know the AI system in the current solution is predict the probability of eukaryote by a machine learning model. And later, Dr. Chen's group will talk about the details and processing of the AI building process. And I will talk about the future solution. We will build an AI predicting pregnancy probability and use the ongoing pregnancy rate as the gold standard. We will collect the patient clinical information, the DNA concentration, the embryo morphology, CNV results, and other data together into the artificial intelligence model. And then we will put an ongoing pregnancy probability in the end, and we will launch this AI model in the near future. Okay, the future is coming. Please welcome. That's all my presentations. Thank you for your patience and time. Thank you.
Thank you, Dr. Yeo. Thank you. It's a great talk. You're covering the history, progress, and also give us the future of NICS. And it's also very exciting to know that the first NICS baby is already 8 years old. Almost makes me emotional. Yeah, so I think we will have some questions, but I think at the end we will ask the question as like a panel discussion together. So thank you very much for your talk, and we will talk about the questions from our Q&A session all together. Okay?
Okay.
Yeah. Thank you very much. Okay, so I'm going to introduce the author of the next talk. It's Dr. Chen Li. Dr. Chen Li is the Deputy Director of Department Reproductive Medicine Administration. She is also a chef physician at the Eastern Theater General Hospital. Dr. Chen has almost 20 years of clinical and research experience in the field of infertility. For example, in their hospital, they have around 2,000 egg retrieval cycles per year, and they can achieve more than 60% of pregnancy rate per cycle. Dr. Chen has been actively involved in academics, hosting research projects, and published more than 40 papers, making remarkable achievement in this field. She is also one of the doctors who have successfully helped us develop, improve NICS technology to help thousands of patients to realize their family dream. And today, she would like to share with us their experience of NICS in their hospital, but herself won't be able to present. Here we are glad to welcome her colleague, Khadilia, to cover her talk. And you can see the topic is best practices in offering NICS. Big welcome.
Good afternoon, everyone. First, thanks Yaxin Yao for her amazing presentation, and thanks Nana Li for her warm introduction. I'm Dr. Khadilia from the Medical School of Nanjing University, affiliated Jinling Hospital. Unfortunately, Professor Chen is unable to join us today due to unforeseen circumstances, so I will be presenting this research on her behalf. Thank you for your understanding. My presentation will be divided into two sections. In the first part, I will share insights on the user experience with NIPDT at our NICS at our center. In the second part, I will provide updates on our advancements in clinical research. To start, we recognize that pre-implantation genetic testing for aneuploidy is widely used to select embryos based on their morphology and genetic health. However, this approach comes with several challenges. The biopsy process is complex and invasive, as it requires the extraction of multiple cells. If the embryo is of low quality, this procedure may impede its normal development. Additionally, analyzing cells from a biopsy carries the risk of false positives in various scenarios, which could result in the loss of viable embryos. Embryomorphism also presents a risk of misdiagnosis. Most importantly, couples often express concerns about the potential harm that TE biopsy may cause to the embryos. This is where non-invasive PGT or NICS becomes relevant. NICS is a non-invasive method that features a straightforward sampling process. It utilizes artificial intelligence and big data analysis to predict the genetic information and implantation potential of embryos, providing valuable clinical insights. As shown in this figure, NICS employs blastocyst culture medium and incorporates specialized NICS amplification and library construction techniques. After sequencing the library, AI analyzes the data based on CNV results to determine the optimal order for embryo transfer. At our center, we collect the culture medium used from day 3 until just before freezing or testing. To prevent maternal contamination, we remove the granulosa cells surrounding the embryo on day 0 and 3. On day 3, when we change the culture medium, we wash the embryos 3 times and maintain them in individual microdroplets while monitoring their growth. Once the embryo is fully expanded, we use a laser to shrink the blastocyst and then collect both the culture medium and blastocyst flood. Next, I would like to share the recent advancement in our NICS research at our center. In collaboration with Econ, we have successfully developed an embryo screening program that leverages AI analysis of spent culture medium. The creation of our AI analysis models involved several important steps. We began by collecting paired samples of biopsy cells and embryo culture medium. Following this, we performed CNV detection on both samples and extracted features for machine learning. The results were then classified into 3 categories, A, B, or C. The features we analyzed include euploidy and aneuploidy at various resolutions, as well as the mosaicism rate across different segment sizes, resulting in a total of 11 distinct features. Our initial studies using NICS-A revealed that clinical samples were classified as grade 8, which is 37%, grade B 29%, and grade C 34%. The probabilities of euploidy were found to be 0.94 or higher for grade A, between 0.7 and 0.94 for grade B, and 0.7 or lower for grade C. Notably, there was no significant difference in pregnancy rates between A and B grade embryos. However, the pregnancy rate, ongoing pregnancy, and live birth rate for grade C embryos were 40.7, 27.1, and 27.1% respectively, which were significantly lower than those for grade A and B. Embryos evaluated using NIPGTA were also categorized into euploid, aneuploid, and chaotic groups. Similar clinical outcomes were observed when comparing A and B grade embryos with the euploid group. It was noted that the miscarriage rate for C grade embryos was higher than that of the aneuploidy and chaotic groups. This indicates that NICS AI can enhance embryo utilization by 20% by prioritizing the transfer of A and B embryos over solely transferring euploid embryos. For patients with grade A embryos, we recommend prioritizing their transfer. If only grade B embryos were available, they may be considered for transfer in the absence of grade A embryos. In case where only grade C embryos are present, we suggest pursuing another IVF treatment cycle. In a follow-up study, we applied NICS to patients with RPL or RIF. A total of 52 euploid embryos were transferred in 43 RPL or RIF patients, resulting in the delivery of 27 healthy babies. With the use of NICS, the overall clinical pregnancy rate reached 58% with 27 live births across 50 cycles. We recently conducted a study examining the application of NICS for male infertility patients diagnosed with severe OAT. Our goal was to assess the effectiveness of NICS in enhancing clinical pregnancy outcomes following ART in men with OAT. We randomly selected 170 cases and divided them into two groups, the NICS group and the ICSI group. To ensure the validity of our analysis, we confirmed that there were no significant difference in male age, BMI, and AFC among the groups. The findings revealed that the clinical pregnancy rate after transferring selected euploid embryos was notably higher in the NICS group compared to the ICSI group. Specifically, the NICS group experienced a 30% increase in clinical pregnancy rate and a 70.51% reduction in miscarriage rates when compared to morphology-based selection. Last month, we published our latest research findings, which involved the use of NICS and PGTA for embryo ploidy detection. This study aimed to evaluate whether NICS and TE-PGT could improve cumulative live birth rates in patients of advanced maternal age. We recruited 384 couples with female participants aged between 35 and 40 years and divided them into three groups, NICS, TE-PGT, and ICSI. Each group was closely monitored and statistically analyzed. Our results indicate that the live birth rates per transfer cycle in the NICS and TE-PGT groups were significantly higher than in the ICSI group. We further stratified the transferred embryos by morphological grade. For good quality embryos, the TE-PGT group demonstrated a significantly higher live birth rate and a notably lower pregnancy loss rate compared to the ICSI group. In the case of fair quality embryos, which is BB grade embryo, the NICS group exhibited a significantly higher clinical pregnancy rate and live birth rate compared to the ICSI group. However, for poor quality embryos, the differences among the three groups were not statistically significant due to the limited number of cycles. For women aged 35 to 40 years, the use of NICS and TE-PGT can enhance the cumulative live birth rate. We recommend NICS for embryos with fair or poor morphology, given its safety and non-invasive nature. NICS may serve as a valuable alternative for pre-implantation genetic testing. In conclusion, I would like to highlight the advantages of NICS testing based on our findings. NICS technology is a non-invasive and safe method for embryo screening. Our research indicates that AI-based NICS can optimize embryo utilization and improve clinical outcomes for patients experiencing recurrent implantation failure and recurrent pregnancy loss. Additionally, for women of advanced age, particularly those with poor embryo quality, NICS presents an excellent option. Thank you for listening.
Thank you, Katrina, and thank you for your talk, and can see the development of NICS AI model, and it's encouraging to see with this AI model we are able to increase the utilization rate of embryos. Also, I can see we have showed the evidence to help BRIF and RPL patients. That's very significant clinical use. Thank you very much, and say hello to Dr. Chen for us. And we will leave the questions at the end. Okay, now it's time to move on to our third speaker. Sanchen, hi, I can see your face. Yeah, so just to give a brief introduction. So Mr. Sanchen, he is a board-certified level 2 genetic counselor, and he has 6 years of experiences in the field of genetic counseling, and he has interested area including preconception, infertility, and pre-implantation testing, prenatal, postnatal, pediatric, basically everything. And he has been invited to many big conferences and talks to share the experience in this field. And we have been working with their company for the use of NICS for a couple of years now. And I believe will give us very good insights of this topic. And welcome Sanchen and give us the talk. Challenges faced in implementing NICS. Thank you very much.
Yeah. Am I audible?
Yeah, I can hear you at least.
Thank you for the kind introduction. So I'll just present my screen. Do let me know once it is visible.
Sure.
Okay, yeah. Is it my screen visible?
Yeah, all good.
Okay, yeah. So first of all, before starting the session, I would like to thank the organizers for giving Lilac Insights an opportunity to share our experience of working with UConn and our experience in NICS. Before we can proceed, just allow me a minute to introduce Lilac Insights. So as Nana mentioned, we have been one of the first company to associate with UConn Genetics in genomics in launching the NICS in Indian market. But prior to that, Lilac Insight has been one of the leading genetic testing laboratories in India. We had a very humble beginning in 2011. Oh, sorry, the slide is not moving. Just give me a minute, please. Yeah. So as I was saying, we had very humble beginning in 2011, and the whole idea behind Lilac Insight is to be one-stop solution for all genetic testing services in India. So we have a very diverse portfolio ranging from prenatal genetics to metabolic genetics and clinical consultation, wherein I actually am a part of it. Recently in 2021, we started our infertility or an IVF segment, and NICS was the first product that we launched in India. And since then, since the 2021, I mean to say 3 to 4 years of experience, we have done close to 20,000 embryos. And with this, I would like to share our experiencing in implementing the NICS. The overall journey has been quite fruitful and we have seen successful results. But at the same time, there were certain challenges. And as and when we moved forward with NICS, we came up with innovative ideas and tried to address those challenges. And today I'll be sharing few of those challenges with you here. So the first and foremost challenge while launching NICS in the Indian market was that the community that we cater to, the clinical consultants and the embryologists, they are broadly divided into two categories. One, who are not a user of NICS, and the other ones who are actually a user of NICS or have experienced NICS prior to Lilac launching it in an Indian perspective. Okay, so the major challenge here is from a non-user perspective is lack of awareness, skepticism towards NICS, preference towards PGTA because PGTA has been there in the market for almost close to 10-12 years. And last but not the least, there are certain group of individuals who do not believe that PGS in general has a significant utility and can improve the overall success of an IVF. On the other hand, when you talk about the users of NICS who have had experience with NICS in the past, the major challenge is constant comparison with PGTA. Number one. Number two is understanding the benefits of NICS. Okay. They might have not had a good experience with NICS. The clinical pregnancy rate and LBR might not have increased in the past. So they feel that the NICS is not on par with or at par with PGTA. And third and most important is the lack of adherence to the protocols. NICS has a distinct protocol that needs to be followed, and it is quite difficult to incorporate NICS protocols in the current IVF setup. Okay. So what we did is when we identified these challenges, we came up with a specific solution to cater to both the groups. So the first and foremost being creating an awareness. So the ones who are not aware about NICS at the first place, we organized multiple CMEs and RTMs with stakeholders, and we reached out to leading IVF chain in India to create an awareness at the first place. Second, highlight the utility of NICS on a global perspective. There is limited data available in Indian context. So highlight the clinical utility, highlight the evidence that is available on a global scale. Third and most importantly is constant communication. And before we onboard a center for an NICS testing, is to ensure that the lab and the processes there are validated. This could include the culturing processes, this could include the sampling technique. So we always perform a validation process. And last but not the least, we have a scientific experts here at Lilac Insights who reach out in person to the centers who are being onboarded. And we have this constant follow-up. And initially during the onboarding process, we ensure that we handhold them right from the time of right from the time of culturing to sample collection and even when the report is released. So me and my team are consultants who are available on board, and then we reach out to the IVF centers or clinicians to explain them about the report results, how to counsel an individual, and if required, visit them in person to help manage their patients. Okay. So once we create an awareness and once you onboard a center with the thought of trying out an NICS, the second challenge is adoption at the center level from an embryologist point of view, because embryologist is the one that who will be doing the entire culturing process. So every lab has its own protocol of culturing the embryos. Some of them might already be doing PGTA. So it is very difficult from them to deviate from that process, or at least create an opportunity for them to place NICS in the current protocol. So what we have noticed in the past is that it is difficult for the centers, and there are some centers who are facing challenge in incorporating NICS. This might be because NICS requires a separate droplet culture. You cannot do a group culturing, okay? And then you need to do a day 3 wash. These are some certain examples wherein which may not be there in place while you are doing PGTA, or the ones who are not at all doing PGS for any kind of PGS. So it is very difficult. Second, there is this one notion that NICS involves higher media consumption, attracts a higher media consumption and other consumables. It is not exactly true. I'll be coming about that in a minute. Third, importantly, how to tackle the challenge of maternal corona cumulus, the maternal DNA that is coming from corona cumulus. Fourth is how to tackle the challenge of increased susceptibility. NICS is a very good, we have had very positive results, but at the same time, NICS is highly prone to contamination if the protocols are not followed. Fifth, now that in past 4 years, multiple companies have been started offering NICS, there is this confusion that is being created in the market on how much amount of sample that needs to be sent. Some companies may ask for 10 to 15 microliters. At the same time, some other companies might ask them to send 50 to 60 microliters. So what happens is an IVF center is highly confused, and most importantly, the embryologist is confused as to what would be an ideal sample that needs to send out. And last but not the least, even after taking precaution, there is always a probability if that there might be a contamination from other sources. So the question that we get to ask is, suppose there is a contamination even after taking all the precaution, can you identify it during the time of analysis? So what we have done on our end is that we have done a stringent, so we follow up with all the centers that are associated with us, and we ensure that the protocols are followed and everyone adheres to it. So there is a constant education that is being involved. Second, hand holding, as we talked about, hand holding goes through and through. It's not just you do it at the beginning and then you stop it out. So we have a quarterly or biannual review. We do that. Secondly, highlighting the importance of one embryo per culture droplet. You cannot do a droplet culture. We have been very particular and we have reached out to centers to tell them about sequential culture option, or you give them an option of one-step media culture. Okay. And as the previous speakers were talking about denudation and wash, it is most crucial. So if a center comes to us with the question of how to challenge the problem or how to tackle the challenge of corona cumulus, we give them an answer that you do need to do a day 3 wash and a thorough denudation before you set up a culture. And wash more number of washes. It's not 1 or 2. Sometimes you have to give a 3 wash to ensure that the CC cells are not present or other cellular debris are ruled out. Fourth, use of filter pipettes. When it comes to PGTA, since these centers are well versed with PGTA protocols, what may happen is they might be using the same filter tips or micro tips while even doing NICS. And there was this concern that using filter tips would increase the overall cost that goes into NICS. So what we did from our end is we started supplying these filter tips from our end to ensure that the clients or the IVF centers are using it. This overall has drastically reduced the contamination rate that we are talking about, the no-call rate that we are talking about. This has drastically reduced. And last but not the least is adherence to good lab practices. The entire sampling protocol or the process needs to be done in an LAF or biosafety cabinets with use of PPE. Mandatorily, this would allow us to circumvent the contamination from the IVF personnel or the lab personnel or sometimes even an embryologist. Okay. Yeah. So these needs to be followed up, and we have been actively following up with all the centers that are associated with us. The third and most important that is comparison with PGTA, whether they are on board and started doing NICS or they are already performing NICS. One thing that is constant that we have seen in past 4 years of our experience is every report that is released out, there is this idea of comparing it with PGTA. And yes, of course, this comparison is bound to be there for another 4 to 5 years unless the NICS is established as one of the alternate technology out there. Now, why is there comparison? One, standardized cutoffs. PGTA has been there in the market for about 10 to 12 years. There are multiple articles published, guidelines are available, cutoffs are there in place. Second is simpler reporting format. If you see, if you screen hundred or thousands of PGTA report, generally these reports are bifurcated in such a way that you have answer in yes or no, whether it is euploid or aneuploid. The mosaicism rate in PGTA is fairly low. So as a result, the IVF clinicians are not used to seeing a mosaic embryos. Third, there is this notion that NICS has a slightly higher mosaicism rate, which may be true in certain scenario. And last but not the least is higher inconclusive and failure rates in NICS. Yes, again, this might be true in certain scenarios, but on our end, we have taken multiple steps onto it. The number one being how to compete with PGTA. So though there is no as such formal recommendation from various international societies, at this point in time, we have updated ourselves to latest PGDIs and ESHRE recommendations to ensure that we are at least on par or at par with the PGTA reports. Second, the notion that mosaicism rate is quite high. Actually, it is not true. Embryos are known to be mosaic. If you read any articles, it is said that at least 40% of the IVF embryos are mosaic in nature. It's just that we are not used to seeing those mosaic embryos when you are doing a traditional PGTA. And when we started doing NICS, those mosaic numbers are bound to increase. It's not that NICS is favoring mosaicism. It's just that it was not being highlighted in PGTA. And why is that? Because in PGTA you're only doing 4 or 5 cell biopsy and then testing those 4 or 5 cells. So you are bound to get low level mosaicism. Third is we created a unique report format with very simpler interpretations. At the same time, we started giving out a embryo prioritization score that would allow the clinicians to shortlist the embryos and then make a quicker decision while counseling the couples. Okay, we have been constantly following up with IVF centers. We have created an engagement program and a quarterly follow-up that I was talking about earlier. So we monitor the results of every center that is available with us. And if we see any deviation in the results, we immediately reach out to the team at the IVF lab, and then we inform them possibly there is a chance that the protocols might have not been followed, or there is a slight deviation, or there is a change in hand, or there is a change in embryologist, because of which we are seeing change in the or deviation in the results. We are also reviewing the lab protocols on a biannual basis and looking onto the culturing protocols. Our team of experts visit to the IVF centers as and when required. And last but not the least is incentivizing the option of repeat testing. So even after doing everything, there is always a probability that you may find an inconclusive report or you may find a failure report. Okay, but it is not the technology which is giving out an inconclusive report. It might be because of two reasons. At least this is what we have used, or LAFs are not being used. The second most important thing that we have noticed, so since initially initial 6 months, we noticed that the no call rate is increasing for any center that we are onboarding. We did a pilot project wherein we started repeat testing the sample that came out to give that would give us an inconclusive rate, inconclusive calls, or a failure call. And to our surprise, what we noticed that on repeat testing, approximately 70% of the embryos had a very high level of mosaicism, that we call it as complex mosaicism here at Lilac, or they were aneuploid. So it is also possible that because it's an intrinsic nature of the embryo, since it is aneuploid, the cfDNA that is being released out in the spent media, it is highly fragmented, and this fragmented DNA in turn ends up as a noise when you are analyzing. So that might be one of the reasons. This is something that we need to work on. It was a basic pilot study that we did last year, and we are building upon it, and we are increasing the number of embryos that we are repeat testing. So incentivizing is a very crucial role. What happens is if we charge the clients for repeat testing, they would in turn pass on the cost to the patient, which would in turn increase their overall IVF treatment cost. Yeah. So this is the report that I was talking about. We have created a unique format, so which includes grade. We summarize the result and most importantly give them the priority score. The euploid always goes as #1 priority, followed by low level mosaicism and high level mosaicism in some cases if there is no euploid embryo available. Okay. The challenge number 4 and most crucial challenge is clinical outcome. And this is the one that we are dealing with right now, and I guess we'll be dealing with it or handling it in another couple of years as well. One is increased amniocentesis rate. Why is that? Because nowadays clinicians are transferring mosaic embryos, and as per the guidelines available, amniocentesis becomes quite crucial in identifying them. So yes, there is an increase in amniocentesis rate. Second, there is increase in the cost due to confirmatory test. Okay. But again, this cost increase is very marginal. If you take a cost of amniocentesis and then compare it with the entire IVF cycle rate, it is hardly fraction of it. It's just 1 or 2% of it. But at the same time, this confirmatory testing gives you a peace of mind. So from a patient perspective, yes, there is an increase, but then it also gives them a clarity and then helps them to be at ease for the rest of the pregnancy. Yeah. Third is embryo wastage due to mosaicism. Though there is a consensus to transfer low-level mosaicism, there's a growing consensus, but not all clinicians prefer transferring mosaic embryos. So what happens is whenever you give a mosaic embryo, there are few clinicians who would only prefer to transfer euploid embryo. As a result, the mosaic embryos are not being transferred. So it is not the technology fault per se. It is it is from an individual's perspective, and it is from the clinician's point of view whether they are not transferring the embryos. So it's not the technology that is to be blamed. The genuine concern that is arising right now in an Indian context is the lack of outcome data. Okay. Fifth is reduced implantation potential and clinical pregnancy rate. This is not a general that I'm talking about. We have been associated with multiple centers in India, leading IVF chains in India, and we have conflicting data that is coming in. So some of the centers would say that they have a very good overall results with NICS. Their implantation rate and live birth rate has increased tremendously. But at the same time, there are few individual smaller chains that would come back to us and tell us that their overall clinical pregnancy rate has gone down, or at least is not on par with what PGTA could offer. Okay, so we are not denying these challenges. So we are working with all the centers that are associated with us, and we have been pooling in data. So it's been 4 years that we launched NICS in an Indian market, and for past couple of years, at least 2 years, we have been constantly engaging with these centers to get back to us with the clinical pregnancy rate, the live birth rate, and we are trying to collate the data. And once we have this data, we would then be in a position to publish it. And publishing, so more the articles we publish, it would act as a support to NICS, and it would help us put NICS in a position wherein we can have NICS as an alternate testing options to PGTA, which is currently lacking. So this is the step that we have taken it from our end. But the need of the hour is that we all on a global level collaborate. So we have been in constant touch with ECON, and we thank them for their constant support. But the need of the hour is that every lab that is doing NICS to collaborate and come up with the clinical outcome publications. More the evidence, it will help us put NICS, as I was talking about, in a position, in a strong position, and it will also increase its appeal, and it would also improve the acceptance rate among the clinicians. So this is something that we need to work out, and we should have a common goal to have more publications as much as possible. And I guess in a couple of years, we would have that. So with this, I would like to thank, and I would like to end my session here. I am open to questions, and I thank all the audience for their patience listening. Thank you very much.
Thank you very much, Session, for your talk. As a technical person with NICS for 3 years, I understand every single item you have talked about, but it's also it's great to hear from the user side, you know, the way from the beginning to the end, how you implement this pipeline in your lab and the users you face. And I think from us, we are working very hard on the new technology to exclude contamination, have more accurate results. And you can see Dr. Yo's talk, we also combine AI technology to give more precise prediction of the transfer order. Yeah, also we are open to, actually, you said lack of research data for following up, etc. We are always very excited to have more people joining us with some research projects, and this is all open to our users. And again, thank you very much for your talk, and that's very inspiring. Yeah, and we will leave the questions at the end, and I'm sure there will be a lot of questions coming up for you. Thank you again. Okay. So it's time to welcome our last speaker, and I will give a brief introduction, Dr. Hu Xuanzhang, and he achieved his medicine degree in National Taiwan University College of Medicine. He is the moment CEO of Gene Infertility Medical Group, which includes quite a few centers, and he has been very keen in adopting non-invasive PGT and made great progress. Today, we are very excited to have him to share with us his insights on NICS with us. And his topic is Explore the Perspectives on NICS. Dr. Zhang, a big welcome.
Hello, everybody. Good morning and good afternoon. I was Dr. Chen from Taiwan. Our topic talking about explore the perspectives on NICS. Last year, I was presented this kind of topic in mainland China. The first medical conferences in mainland China, Nanking. About 3 years ago, my clinics have do the NIPGTA, and we compare the MIPGTA. We do the MIPGTA because we think the MI, minimally invasive, can bring many benefits. So from then on, we also use the MIPGTA for the NICS preparation. And we compare the MIPGTA and the IPGTA and the ICM sampling for in our preliminary report. We found that the sensitivity for the MIPGTA is about 83%, and the IPGTA is about 100%. But the specificity is much better for the MIPGTA, but the IPGTA is less, not efficient to detect the chromosome normality. And the concordance rate for whole chromosome copy number is about 74 for the MIPGTA, but the IPGTA is about 52%. And the most interesting thing is about this kind of do we have to use the combined spindle culture medium with the blastosphere fluid for amplification, for extraction of the DNA for amplification? We found that in our preliminary results, we found that if we use the two combined spindle culture medium with the blastosphere fluid for extraction of the DNA, is much better, 96 informative results compared to the only spindle culture medium, only 68% informative results. And from then on, we use the two combined spindle culture medium with the blastosphere fluid for extraction of the DNA. I also reported this kind of give a topic in Taiwan 2 years ago. Now the NIPGTA or the NICS, I think many questions have to answered, but from 2 or 3 years ago, about 100 many papers also published, but I think the limitations still exist. Why? Because the origin, the representativeness of the cell-free DNA, the molecular characteristics of DNA fraction, the contamination, the decision-making for priority of the embryo single embryo transfer also have limitations. But I think after 2 or 3 years, there was much improvement in such limitations, and later we will present. If we discuss about the cell-free DNA for the NIPGTA or the NICS, we think we have to understand that if we are talking about the concordance, we have to know it is a clinical concordance or karyotype concordance or chromosome level concordance. And the global contamination, the origin, and the sampling method, the sampling time, the embryo treatment or detection method, all concerns with the success of the NICS or NIPGT result. But because after 2 or 3 years ago, and later, many papers was published concerning the clinical results. I also do about 2 years. I also do a small case for the clinical results of the NICS and compare to the morphology. As we know that, what is the NICS? It is a non-invasive competitive screen. It was developed by the Econ Genetics. And the Econ Genetics have used the NICS, have published until today about 25 papers. And recently, 2024 have 4 papers is published, and we will present these 4 papers later. And we also know that multiple center held by the Chao Jie, a very good and excellent professor, And the results, I was heard that it will be presented in the end of the 2025, the clinical results. Now, this is very smart and excellent paper. I have read this paper for 100 times. I can memorize it, but before they have talked about this paper, so we just missed this paper because they are grading for the ABC, and this, I think this is a very good paper, excellent paper for the developing of the NICS A or AI, or the NICS A is a very good paper. And we know that if we are using the NICS AI, we have to know that how to standardization of the sample collection, the NICS have already done. And the NICS A also include the NICS instant one-step librarian and the chromosome instant auto analysis platform also developed. So using this kind of procedures, we can use the NICS AI for many advantages. And now we are introducing the clinical application of NICS. In our because our case number is not big enough, but in the compare of the econ and my gene IVL center, the application for the NICS A, we see that the A grade embryo have the 46% clinical pregnancy rate if it is a donor cryopreservation group. For the fresh group, we have 47 clinical pregnancy rate. But as for the B grade embryo, is a lower clinical pregnancy rate, only 11 pregnancy rate. And however, if for the fresh group, we can achieve about 40% of clinical pregnancy rate. This is raw data from about 2-3 years ago. I do in my own clinic. I found that an interesting thing, because if we found that we have a very about 20 to 25% of a very interesting thing. If we see that the MIPGTA result and the ICM results and the TE results, we found that the MIPGTA results is better compared to the ICM results, because we found that the TE biopsy about 30% false positive rate. So we think if we use the TE biopsy, we have to know that you have bring a 30% false positive. This is very confusing things for everybody. Now we see the clinical paper. For clinical paper, we found that this is a paper from one fertility center from Canadian. She's published in this year, May. The major point, he pointed out that if we use the spindle culture medium with the blastosphere-free combined, we can find a better informative results, just like 2 or 3 years ago. And I know that in the NICS AI group, I think everybody is using the mini invasive that already found, already seen in 2 or 3 years ago in my clinic. And they are, this paper is frozen the day 3 embryo and cultured for 48 and 70 hours, 72 hours culture time. And they found that if we culture longer time, can have the much better for the NICS result. And this is a very interesting paper, was published by Wuhan Tongji Hospital. This May published. She compared 3 arms. What 3 arms? She compared the NICS and the timeless, and the NICS combined with timeless. He compared the 3 model, and we found that for the timeless model, the AUC is about 0.76, and the NICS model is about 0.91. And the AUC and the NICS combined with time lapse much higher for the 0.94. AUC, and we compare the accuracy. We see that the time lapse is about 0.72, and the NICS is about 0.84, and the NICS combined with time lapse is about 0.86. And comparing these three models, we also found that the euploidy probability comparing, we found that if the euploidy probability is less than 0.3, the time lapse has 3.3%, and the NICS group has 33.7 percentage, and the combined NICS with T time lapse about 38.6%. But we see the lower, if the probability is higher for the 0.7, we found that for the two combined have a much higher good probability embryo. But if we only use the T time lapse, you can see that the all gathering in the point lower than the 0.3 or higher than the 0.7 is very low percentage. It was in the middle, 0.3 to 0.97 probability, so much percentage. So if we use the time lapse with the NICS, I think it is a better accuracy and the precision for the future. This is a good paper. This is a very good paper. And we also see the, but this paper was already mentioned. So we just let it know that we are also doing this, but because our case number is scheduling, he compared it with the NICS group and the control group, only each group. And they found that's already mentioned before, just 1 hour ago. Let's see that the clinical pregnancy rate, ongoing pregnancy rate, and the live birth rate is much higher for the NICS group compared to the control group. Even for the older age, for the 35 years old patient can bring good benefit from the NICS. But in Taiwan, because our patient is much higher for the age, advanced maternal age, or covering about 50 to 60% of population, fertility population. So we all use in our study, we use the patient larger than the 36, but the number is not big enough to publish a paper. But we cannot really, until now, we cannot see good results. I don't know why, but we are wondering, this paper is good and we can compare, but the results is not so good for the NICS group right now. And this is a three-armed, very good paper also. So they have already mentioned, so I don't want to talk again. Now we have to discuss the ECON. The ECON have the NICS is the original NICS, but the advanced, they're using the ECON NICS A for the AI grading. For the AI grading, they can grading for the embryo for the A grade, the B grade, the C grade, and the AB grade can be transferred, but the C grade is not suitable for transfer. But the maternal contamination, they already mentioned that if we use the parental and the maternal specimen, we can differentiate. Use the NIP method, we can differentiate this contamination is from the parental or maternal, but this is the cost, and the cost benefit is not adequate for performed routinely. But I know that ECON is developing a new method and published right now. They use the methylation method to know the sample from the spindle culture medium and the blastosphere fluid. They can animate or identify, use the restricting enzyme and methylation to know this specimen and the cut of the maternal and the parental contamination. But we compare the different from Europe, a different embrace also using the NIPGTA, but I think the NICS have much advantage. I think right now, last one, I want to tell you that what is the take-home message? SOP, I don't want to say it again, but I know the AI, the NICS uses the bioinformative algorithm, and they are also uses some method to correct the contamination, and they can also differentiated the copy number variation, noisy copy number proliferation. They can do the discrimination, and they can also know what is the origin of the DNA. Just I already mentioned. But I think in this, in my talk, I think this can be done only a screen method. It is not a diagnostic method, because the PGTA also have the false positive rate, maybe very high, but if we transplant euploid iPGTA, I think the baby is good. But if we use the A, B, C, we have to know that if you transfer a A-grade embryo, it may be have chromosome anomaly. But you have to say to the patient that it is a screening method. At present, I think it is not suitable to replace NIPGTA. I think it is not suitable, but because the safety of the embryos and the children is positive, and I think we have already know that the clinical application maybe have such many items, but last one, I think it is very important to get a confirmed and a good explanation to the patient, because the infant consent and well explained to the patient is most important in my opinion, because I was doing the medical legal dealer with in Taiwan. I have met many papers in legal problem, and I will deal with them because I was a good technician, a good doctor, and also a good counselor for the legal problem. As we mentioned, the Monash, in the Monash, they have the encounter very lawsuit for the NIPGTA. So I think how to explain to the patient and give a good infant consent is very important. If we want, in the future, we want to use the NICS-A or NICS-AI or for the clinical application, I think it is very important for the infant consent. However, it's very challenging for use the NICS in the near future for clinical application. But I think there is still some challenge to be solved. Thank you for your listening. This is the last slide. As I mentioned,
I think that is also a lot of patients on the users' question as well. Thank you, Dr. Zhang. Thank you. I think it's a very good slide that previously you showed the clinical application that give us. We have been working very hard on how to adopt this method as well. You know, at the moment, it can't be a complete replacement for PGTA, but it has its, you know, its advantages and specific clinical use that can give us advantage. Some, for example, some more for the more older women, maternal age, more advanced, for example, some embryo poor quality, etc. And yeah, so thank you again. And we have collected quite a few questions, and all the speakers are welcome to join our question session. And I think I will pick up some questions, and some are asked during the talk, but I cannot 100% separate the questions now. But I think from the questions picked up by my colleague at the moment, the first topic, a lot of them mentioned about the comparison. So following your talk as well, there's a slide showing invasive, non-invasive, you know, different scenarios. A lot of them also mentioned they cannot help to compare between invasive, non-invasive. So the first question probably will be like, what is the accuracy level, both invasive and non-invasive, and the comparison between two? I think Dr. Zhang's slides mentioned this. Maybe you can expand a little bit on this topic for us and your idea, and others can join also. I think you muted yourself, Dr. Zhang.
Excuse me, could you one more time your question, because I will leave for the water. Okay. Once again.
Yeah, of course. I think a lot of questions are covering about the comparison between these two approaches, invasive, non-invasive. Because I can see your slides sharing us experiences. So a lot of people asking about the accuracy level, invasive, non-invasive, and between this concordant rate between these two.
We don't have to talk about the concordance, because if you really compare the concordance, no matter at the chromosome level, clinical level, or chemical type level, because everybody only do the concordance rate for the clinical level, euploid or aneuploid. But I think if we compare these two models, NICS or the IPGTA, I want to tell you one thing: the concordance rate even 80%, but the concordance rate still have some confusion. Why? Because if you do the TE biopsy, you see that is euploid, but we use the NIPGTA, it's aneuploid. So I think from about 2 years ago, the AI model was applied. I think we only have to talk about the probability prediction. We don't have to talk about concordances. This is AI model, because AI is doing everything. So if we use the AI, we use the bioinformative algorithm to count the embryo is A grade, and we have know that the econ is doing the linear score. For instance, if the embryo is A grade, maybe his linear score is 91, and we can have trust that. But this is only 91%, very good. But it still have 9% unemployed. So we don't have to compare the concordance rate right now. I think it is not suitable to compare the concordance rate. 2 or 3 years ago, many papers concerning the concordance rate. I also do the concordance rate, but I think right now, in my opinion I cannot say my opinion is right. But I think if you compare these two models, entities for concordance comparing, is not suitable right now.
Thank you. Yeah, I can see. So I hope with our development of AI models, so we shift the focus from diagnosis into like screening. We help patients to select the best embryo, and if we see this help is great, then I think it's worth doing this technology rather than from some screening itself, right? So to help the patient have better clinical outcome. Thank you very much. So I think there is also another question about the protocol itself. So I think maybe more people can help. So the user ask about the laser. So can we do NICS without using the laser? So maybe we can share experiences from everyone's center. So for technically we can do. That's my answer. Yeah. So I don't know if during your experiment, do you find it, or do you did comparison between using it or not using? Is there such research reflecting such comparison?
You asking me?
So we can use the culture media released naturally, completely non-invasive, or we can use like a laser and add the blastocyst fluid. Do you have experience that the comparison between this research, or is this absolutely necessary to use this for NICS?
We have do a research, because my chief embryologist is very good with this technique. She's very familiar with this kind of technique. So originally we want to use the best spindle culture media. We want to do the NIPGTA, but we found that it's some advantage, and the informative results was lower. So we try to do the blastosynthesis, but because in our clinics we do the ICSI and we do the biopsy very often. In Taiwan, we can do the biopsy procedure, and we are familiar with the embryo manipulation. So from 2 or 3 years ago, now we do the NICS or do the NIPG, we almost use the blastosynthesis. But you know, recently one paper I have presented from Canada, they also give the same opinion that was the same with us. The combined blastosphere fluid with the spindle culture medium, the extraction of DNA is much better for late application.
Great. I think that also answers another question that, without it, some amplification failure could happen. So, but with the blastocyst fluid, this can be avoided. Thank you very much.
The most important thing, in our opinion, you do the blastosynthesis, it will not harm the embryo. You know what I mean? You only do, because everybody also do the behavioral blastocyst is too much bigger than 160. They also do the blastosynthesis for prevent when they cry or for the prevent or the crystal information. So the blastosynthesis, if you are familiar, is a very easy procedure. I think, in my opinion, in the clinical outcome, I don't see any differences if you do the blastosynthesis or not do the blastosynthesis for the collection of spindle culture medium only. For the collection of spindle culture medium with blastosphere fluid, I like blastosynthesis for the collection.
Thank you.
Yeah.
I think that helps. Oh, Yaxin.
Okay, I quite agree with Dr. Zhang's opinion, and I think the laser is actually a routine operation in the embryo life, and it is a routine manipulate before freezing to ensure that the embryo can pass through the ice crystal phases of freezing. And we just collected the blastocyst value and span culture medium sample that are routine acceptable, and this is also improved the overall success rate of NICS. And using the large scale multiple center data, I remember we found that the routine laser step can increase the success rate of the test by nearly 5%. And in addition, we have another collaboration. I remember name is New Hope Fertility. They perform two lasers can also get good clinical results and NICS results also. Yeah, I think if there is no way to perform the laser, I think there is also another solution, is that we suggest that the system for culture embryo can reduce to 10 to 15 microliter. Is also okay. Yeah.
I answer. Theoretically or physiologically, if you use the combined blastosphere fluid, maybe it can represent to combine. Because if you use the spindle culture medium, there was much contamination and much origin unknown. But if we use the blastosphere fluid, much DNA was from the blastosphere fluid. I think it's much physiological for the chromosome, the status, the true status of the embryo. It's very easy thing, huh?
Yeah, I agree. Thank you.
Yeah, thank you both. I want to ask Sasha another question. I think it's more suitable for you. And there is one question of worrying about the cost of culture media collection, because you mentioned that for collecting culture media, you have to culture the embryo in single droplets. I want to, so Sasha, you have a lot of experience talking to different centers. Do they have this complaining about increasing the cost or anything?
Yes, there is this concern that we used to get earlier when we launched that many centers were quite hesitant, and they used to raise back this concern that the consumption of media increases. But what happens is, if I have to compare the cost of overall IVF cycle, if I have to compare that cost with PGTA, what happens in traditional PGTA, I'm not using a significant amount. I'm using significant amount of laser. I have to have that machines to do a biopsy, and then I need to have a technical expert person doing that biopsy. So this increases the cost. So if I have to compare that with NICS, though there is a marginal increase in the added cost due to the use of extra media, but then you're also reducing the cost of technical expertise, like hiring a person, a dedicated person for that. You're reducing the cost of labor, you're reducing the cost of machines. So overall, if I have to compare, in general, if I have to compare, the cost is significantly reduced in NICS, and that is what the appeal is. So from an Indian context, when I talk about NICS and its acceptance, this is one of the major appealing factor for NICS, that it significantly reduces the overall cost, which in turn the benefit can be passed on to the couples who are opting IVF. So this was a challenge that we faced initially, but I don't think so many clinicians favor that or come back to us with this concern. So now I guess there's a general consensus among the clinicians as well on this part.
Thank you. I think also during my training, I also tell my customers that before changing the culture media, they can culture multiple embryos in one droplet. Maybe in a way, kind of half of the extra cost. And afterwards, they can put them in single droplets. Thank you. I think another big session of question raised is about the gender reporting, like XY, and how are we going to exclude maternal contamination, or is this going to be as effective on both XX and XY chromosomes? I think maybe we can share some insights of it, experiences, and Dr. Yao also can broadcast some of our new technology, probably to exclude contamination about reporting gender more accurately.
Oh yeah, yes. We now corrected XY mosaic through the bioinformatic method, and we calculated the XY mosaic rate, and then we will calculate the maternal contamination rate and correct by informatic analysis, and that's the one solution. And there is still another solution. That's the in the bench set. We will launch another maternal contamination correction method that is DNA methylation. Yeah, we want to we will show the maternal contamination ratio based on the DNA methylation, and we will correct it also through the bioinformatic, and then we find it is quite similar to the T biopsy, and also better than the current solution corrected by the XY mosaic rate. Yeah.
Thank you. I think we are also actually developing new methods combined with AI. We are continuously working on this. It is very challenging, I have to say, but I think we have achieved quite good accuracy. At last meeting I attended, we are looking at 94-95% of confidence. Yeah, so that's good news. I think there are some more about AI also. By using NICS AI grading system, usable embryos are increasing. The euploid ratio of A plus B on your grading system is equal that of whole genome PGT. So the euploid rate tested by AI. So when we rate A plus B, so what is the euploid ratio? I think it's that question. Equals to whole genome PGT. Equal to PGT.
Okay.
I guess it's more about asking the clinical utility, like so if I have 100 embryos that I have tested, how many embryos are actually usable and transferable if I grade them as A and B? I guess that's the question.
Okay, in our research, we have found that the utilization of NICS, which means grade A plus grade B embryos, are 78.8%, and the proportion of the euploid embryos is 57.9%, which means that the utilization of the embryo has increased 20% by using NICS AI. Because there are some percent of the mosaic, we know that there are maybe some percent of mosaic embryos are testing and could be classified as non-euploid, not aneuploid, but it may be chaotic. But these kind of embryos may be usable and can give birth to healthy child. So when referring to this kind of chaotic embryos, NICS can increase the embryo utilization by grading this kind of embryo to classify this kind of embryo to A and B plus. This is my explanation.
In my opinion, I want to address a very important thing, because we are clinician, we are a doctor, we face the patient. The NICS, for instance, we have to see that, and we don't know that. If we use the PGTA for the routine procedure in Taiwan or in other countries with the very, very advanced age, you cannot do the biopsy because you have no embryo to do the biopsy. And maybe some patients don't want to do the TE biopsy, but or some instances you can damage the embryo, maybe they will worry about it. But I want to tell you that I have a slide concerning the clinical application of the NICS AI is very important. If you have the embryo, your experience is very good. You manipulate the embryo, you will not harm. If you do the TE biopsy, you can do, and the patient wants you to do. But in some circumstances, you cannot do the TE biopsy because you cannot find a good embryo. So we use the NICS to optimize, and the grading ABC to optimize our priority for SET. This is very important for some patient. This is I want to share with this opinion.
Yeah, that's very important, because with more technology, we are very glad to provide our patients more options when they have, limited embryos. Exactly, right. So I think, more.
I have a question to the technicians. We know that DNA application failure has been raised in many literatures as a hurdle for promoting NICS in our traditional ART procedure. So I want to know, is there any progress in this aspect? Because Dr. Chan has said that the MI-PGT plus NICS has a great promising future in our ART. So I think maybe this is because this is a little result of the DNA amplification failure in our traditional NICS. So I want to know if there any progress in this aspect.
So for this question, the two answers. First, you can use laser to add the amount of DNA. So if you are bothered with an DNA result and it has to give a report, you have to see the results. Also, internally, we have been implementing the idea that if for NICS result is NA, you can basically exclude maternal contamination and to have like very confident conclusion that, okay, nothing is amplified. We tend to refer to the doctor to transfer instead of wasting the embryo or call it NA. It's not an NA. It means the cfDNA amount is very low. It's a fact. It's not a failure. It could indicate this embryo is actually quite good. So there is not much, wrong information to repair that. That's also an idea. But I can understand the labs struggle with giving an AA result if they have to do again. And so using lasers seems quite practical at the moment, at least. Or they can reduce the culture media droplet. There's also another question about the droplet size. So basically, if the culturing time is quite short, using time lapse, for example, you only do it on day 5. It's a couple of hours. Instead of using 20 microliter, they could just design the droplet around like 10 to 15. So for the NGS lab, the DNA is more concentrated. So we started with the same volume anyways. So they can either use laser and reduce the droplet size, or they can consider to report this NA result to look at in a different way. I think scientifically they all have their advantages, but depends on the specific lab. What do they think and how the users accept it.
Thank you.
No worries. There's another one that I'm not sure. So there's a question. Can you do the laser on day 3 embryos and collect spent media on day 5? I don't know specifically anyone has experience on this. Using laser on day 3, but collect the spent media on day 5.
We haven't, at least here, we haven't experienced. Generally, here what we do is just prior to the sample collection, a laser shot is given and we collect the samples. At least I haven't come across any clinician saying day 3 laser then collection at day 5. At least we haven't here in India.
There's another question about frozen cycle, like for embryos that we understand need to do rebiopsy. Some of them might consider non-invasive. If it's a rebiopsy, we might consider non-invasive because obviously if an embryo already been biopsied once, it's quite painful to think about a second biopsy. So, but based on our research, all of you can add on that as well. So actually, for the thawed frozen embryos, surprisingly, the contamination dropped almost like to minimal level. Actually, for the frozen cycle, for NICS frozen cycle, the maternal contamination is less concern. Actually, we achieved a very good result with another paper published, like almost more than 98% of the embryos had very good result, valid results. So if biopsy embryo needs to do test again, I think non-invasive is a very good approach to consider. Yeah. So,
I was quite agree with your opinion, because I think if you do the twice rebiopsy, I think it is not suitable to do. If we have the NICS AI, I think NICS AI should be done first. Rebiopsy is not appropriate for my opinion, and we are clinician. We don't want to do the rebiopsy because in my opinion, we also do many rebiopsy, but I think the pregnancy rate or the clinical outcome is not very good for my opinion.
There's another question come up. I think every one of you can share experiences, because I think although we give protocol, econ protocol, I know every center might adopt it slightly different. So what is exactly the correct technique to collect the culture medium? And do you have apart from the econ protocol, do you have any tips to add on that? For us, basically, we of course we want them to wash on day 3 or day 4. If bothered with contamination, we actually try to convince customer wash both on day 3 or day 4 and collect on day 5 or just before vitrification. But now with more and more people using time lapse, and no, it's quite challenging. Also, some embryologists feel a bit difficult to add on their protocol to wash, and there is some challenging facing, right? So what is your tips from your experience of supporting these products?
So generally our experience with day 3 wash has been significantly good. So initially what would happen is the labs would not give a thorough wash. As a result, the contamination would be significantly on a higher end, compromising the overall results. But with a day 3 wash and a good denudation, the protocol is fairly similar to what Econ has provided us, but with just a day 3 or a day 4 wash that you were mentioning, we have seen very good results and a significant drop in maternal contamination. And most importantly, we have few labs who strictly adhere to the protocol that has been shared to them. We have seen the no call rate or the inconclusive rate to be as low as 2% for them. So if they strictly follow the protocols.
Oh,
And that's what we take it as a standard, and then we reach out to clinicians here, or at least the centers here. If you follow this, your results can be something similar to what the best lab here in India is practicing. And of course, yes, the option of adding a laser onto it, if you give a laser shot again, that increases the amount of DNA that you get, and again reduces the overall no call rate or an inconclusive rate.
Thank you. And anyone else want to add the protocol of sample collection for NICS?
Oh yeah, Nana. Maybe I can share some experience. And I think the protocol should depends on the scenarios your IVF center. Yeah, and there is some center they freeze the embryo on the day 5 morning, and I think that is quite short for the culture media collection, and so we don't recommend it they wash it again on day 5. And if the IVF center freeze the embryo on the day 5 afternoon, even on the day 6, I think it's quite suitable for them to collect the cultural medium from day 5, day 4 to before freezing. Yeah, we will have the large scale data have showed that, and if the IVF center choose the day 3 collection method, they will get a 5% increase the information. Yeah, and if the IVF center they just use the one-step culture such as the time-lapse. Yeah, it's quite similar to the one-step culture. They can collect the culture medium on the day 5, leave the time-lapse culture they can collect the culture medium from day 5 to pre-freezing. Yeah, the embryo should culture only for 6 or 8 hours in a single microdrop in a 10 microliter job. Yeah, that's enough time to release the cell-free DNA. Yeah, and we also collect spent culture medium and blasto fluid together. That will get enough cell-free DNA to get an informatic results. Yeah.
Yeah. About this technical information, so we are giving just a briefing, but if you need any more information, you're welcome to contact us. We can support in very detailed documents, training, etc. So we are very happy to share our experiences with anyone who are interested. I think last couple of questions asking more about the research side. There's a question for Dr. Yo since you are speaking. So this NICS group baby weight is higher than PGTA group. Does it suggest TE biopsy have some kind of effects on the embryo development? Can you briefly answer this question?
Okay. I think it is possible that the biopsy T cells may develop into placenta to give
placenta.
Yeah, to give the nutrition to the babies we pregnant, and that the biopsy, if we give a biopsy to the low-grade embryo is not conducted to the embryo implantation, and I think it is possible that it is the reason why the fetal the new baby weights in the T group were significantly lower than those in NICS group, and in the near future we will conduct a further study comparing the TE, PGT, and NICS to find out the potential impact of whether or not to biopsy on the newborn baby by comparing the clinical outcomes and the new baby data from NICS and PGT group. Maybe it is also a large scale RCT. Yeah.
Oh, that sounds inspiring. Yeah, I think for the effect of T biopsy still need more evidence. So hopefully we can have some contribution to these findings and to help people to have wider option when they do IVF. Thank you, Dr. Session, you were raising. Yeah.
I have one question that I would like to ask specifically. So we are talking about, so the challenge that we have seen here is more specifically from a frozen embryo NICS point of view. So if someone has a laser, they can just quickly culture it for about 7 to 8 hours and then provide the sample. But here in India, what we have noticed is not everyone has a laser or at least an infrastructure to have lasers in it. So in that case, then mandatorily they'll have to do an extended culture before we can collect the sample. What happens with extended frozen culture is that the embryo would move into a day 6, which would potentially lead to its hatching. So many clinicians, because of this, they do not want the embryos to be subjected to NICS if they have to do an extended day 5 culture. So is there another possible options? Can we reduce the overall volume of the sample to be sent or reduce the overall culture time if the laser is not being used?
Thank you, Jamie. Yes. I think it's approaching 5 o'clock in China, so I don't know if we can still extend this talk. And we have actually many more questions coming, but I think due to the time limits, probably we will leave some of the questions in the future sessions. We are planning to do more these kind of webinars, share our research progress and use of this new technology. And if we have new products, we are also very excited to share with us, and hopefully we can have more and more these chances to sit together, share our thoughts and experiences with everyone. And thank you very much for
actually
your talk.
I want to add some explanations because I have read a literature that talked about the culture medium from day 5 and day 6, and they said that the embryos were cultured to day 6 as opposed to the day 5 and enhance the concordance of the results. But I think why the day 6 embryo culture media has not been used widely in our NICS technique is because it is a digression from the standard clinic protocols, because we often use the day 5 blastocyst to transfer if the blastocyst has emerged in day 5. So I think it doesn't say that the day 6 culture media is not better than the day 5 culture media, but it's a digression from the standard clinical protocols, so it cannot be permitted widely. That's my opinion. Thank you.
You mean we are not using day 6?
Yeah, I think we are not using the day 6 widely, because if the blastocyst has emerged on has created on day 5, then we prioritizing using the day 5 culture media, not the day 6. But some literature said maybe we extend the culture. Extensive culturing time to day 6 may have the better concordance with the NICS results. That's my explanation.
I think based on, thank you for your question. Based on our protocol, actually, we don't limit it to this day 5. We mentioned day 5 to represent vitrification time. Actually, if the embryo grows to day 6 as it's needed, that is day 6. So basically, it's from day 3 or day 4 to before vitrification. It's not specific, but we see day 5 to simplify it.
Okay, thank you.
Yeah, they both work. Yeah.
Okay, thank you.
No worries. Any more we want to talk about before we having a photo, as Renee asked, with a smiling face? No. And Renee, can you instruct us for the photo you want or anything? I think we are finishing today's session. Thank you again.
Dr. Zhang has opinion.
算了，不要了。
Oh, okay.
算了。
3, 2, 1, smile. Okay, thank you.
Okay, thank you.
Okay.
Thank you.
Thank you.
Yeah, thank you, everyone.
Thank you. Bye.
Thank
Bye.
you for your time today. I hope we can see you next time.
Thank you.
See you.
Thank you.
Bye-bye. Thank you
Bye-bye.
everyone for your time. Bye-bye.
Thank you.
Bye.
Bye.
Bye.